to organize this e-Symposium on Diabetes Therapeutics. And we are really privileged to have a galaxy of speakers and doyens who are chairing the session today. So it is our real privilege on behalf of Indian Pharmacological Society West Bengal chapter, Association of Clinical Pharmacologists in India, and also the Inovocare e-Academy. I welcome all the respected delegates in this e-Symposium. So we have chairpersons Padma Shri Shashank Joshi sir with us, who needs no introduction. He's a doyen in the field of endocrinology in the country, and we have also with us Professor Apurba Mukherjee sir. Apurba Mukherjee sir is the professor of professors. He also needs no introduction. And also we have with us Professor Santanu Tripathi sir, who is the very reputed clinical pharmacologist in the country, and he is the president of ACPI, that is Association of Clinical Pharmacologists of India. Now I am requesting our honorable chairs to start the today's proceeding.
So good afternoon, everybody. It's a very important privilege on my part to start the proceedings of this e-Symposium as pronounced by Dr. Shambho Mujumdar. And it is very important for all of us to understand the diabetes therapeutics as it has evolved over the years. We all know that the therapy started with insulin in 1922, but following that, we have got so many oral drugs appearing in the scenario. And to take us through, may I request our overseas respected speaker, who is also the Vice President of the International Diabetic Federation, associated with the Department of Clinical Pharmacology, Clinical Pharmacy, Industrial Pharmacy of Swipko University of Ukraine, and she is Iryna Vlasenko. And without being in between the learned speaker and the galaxy of audiences, may I request Professor Iryna to start her deliberation.
Thank you very much, dear Professor. I'm very happy that with this introduction.
Madam, may I just 1 minute interrupting just with permission of chair, may I also request, because Joshi sir is also moving towards another place, so may I request some introductory comment from the Joshi sir also?
Yeah.
So thank you, Shambho. I think Apurba is introduced, and Iryna is a very close friend. She's one of the foremost clinical pharmacologists in the world. She has done very good pharmaceutical and pharmacy education for IDF. We all support her endeavor in Ukraine and our brothers and sisters in Ukraine. And she was very responsible for ensuring that there is no insulin and oral medication shortage in Ukraine during the humanitarian crisis. So we congratulate you for Iryna for all your efforts. And we are always there to support you. She's an excellent speaker. And I congratulate Shambho, you and your entire team for this wonderful e-therapeutic symposium, which is a need of the hour. So congratulations to you.
Thank you, Shashank. Very happy to see you. Thank you for your kind words.
Thank you.
Now again.
Now you can share your slides, Iryna.
Okay, thank you so much for introduction. I'm very happy. Thank you very much, Dr. Shambho, for this invitation. I'm very happy with this. And I all the time exciting how very often in Indian colleagues organize different symposium, different possibility to learn, and how many people join to every conference. A lot people want to learn, want to know something new. I hope we can send delivery, but what is you? Can I share screen?
Yes, madam, you can share. There is a share screen option, madam, below.
Well, no. Ah, so that's all. No, this is share.
Yes, it starts sharing, madam.
Share. Well, this is okay. Okay. Just a try. Sorry for this, but it's like a little bit. Did you see my screen?
Yes, yes, madam, it is coming. That PPT is
Yeah, okay. But I don't know what is. So that's all. Slideshow from start. Yeah, thank you, Sayo. Okay, we can start. Today we will speak about pharmacoeconomic in diabetes management. It's too complicated subject, to be honest, and a lot of gap in this. According to our IDF Diabetes Atlas, last Diabetes Atlas, we can see how increase is global health expenditure due to diabetes. And you see that I only want to add that the indirect cost of diabetes add an additional 35% to annual global health expenditure associated with diabetes. And you see during last 2-3 years, it's up very dramatically. But for me, more interesting how countries spend for per person. And you see, we are not in the same level. We are, unfortunately, we are not in same position on this area, and we must work very hard. But in the same time, sometimes it's not depends of our activity, but anyway, we try to find best solution. And this I find some research show that the mathematical model make according to demographic data and product for a cost for 180 countries, and then they find results that absolute global economic burden with increase from 1.3 trillion to 2.5 trillion by 2030. In this case, policymakers need to take urgent action to prepare health and social security system to mitigate effect of diabetes, because it will be absolutely impossible manage. But one of these big part, this is price of insulin. According to some researchers, they show that patients in state spent of average 50% more on insulin in 2016, for example, than they did just a few years earlier. And they continue these trends, and the Endocrinological Society make this position statement addressing insulin access and affordability. And they believe the follow policy changes could help expand access to low-cost insulin. As stakeholders across the support chain have a role to play in addressing the high price of insulin. And new pricing methodologies and policy changes should be tested priority to implementation. And of course, biosimilar. It's big question. We know this is some discussion, many different opinion, but anyway, this is in reality. We live with this, and it's also very good because it's a little bit reduced price, but not all the time. And but in same times, biosimilar insulin demonstrates they are safe and effective, but interchangeably and automatic substitution remain as issue. The FDA and EMA must ensure that the approval process for biosimilar insulin product is efficient, while still ensuring the safety and effectiveness of their new product. I can announce that next week I will go to Amsterdam to European Medical Agency, and we will have some special meeting about biosimilar. It's not only about insulin, but this is like strategy, plan strategy. And I will, after this, I will share with you some news. What about cost effectiveness of alternative strategies to achieve excellent glycemic control in type 1 diabetes? This is a great article. It shows as intensive therapy achieve and maintains excellent glycemic control. The greatest cost of intensive therapy with type 1 diabetes and PAM are suitability offset by the reducing cost of complication, comorbidities and death, and improving in health-related quality of life. They also highlight the economic benefit of delivering intensive therapy as a low cost as possible. This case, we go back to our previous slide. If it's cost less and glycemic control is good, it will super benefit and economic effectiveness. They use expensive insulin and devices as a general treatment strategy will reduce the cost effectiveness of intensive therapy unless they achieve better clinic outcome. In this case, you see that intensive therapy using pump with CGM is not currently cost effective as general treatment strategy because of this substantially greatest cost and incentive long-term clinical superiority. Pump therapy with CGM may be an appropriate therapy for selected patients who have poor glycemic control and problematic hyperglycemia and who achieve improving long-term outcomes with such therapy. This is also good evidence for use this device. Sodium glucose like CGLT2 inhibitors have demonstrated a reduction in cardiovascular and renal complication, including hospitalization for heart failure and renal disease progression in randomized clinical trials. Their findings highlight the need to consider the cost saving from reducing common morbid and preventable type 2 diabetes complication when considering the cost of diabetes medication. This is also very important. You know that now it's strategy for for treatment diabetes is not only about glycemic control, and also we must reduce cardiovascular risk when we use some medication. Next, compare this treatment with dulaglutide once weekly semaglutide, both doses 0.5 and 1 milligram, represent a cost-effective option for treatment individuals with type 2 diabetes who are not achieve glycemic control with metformin. In this case, it's, but anyway, we must look in about people glycemic control. It must be achieved this, not only use medication. Of course, this is very expensive. When we use statin therapy as secondary prevention, there is clear value to statin use cost saving individuals with diabetes and without cardiovascular disease. However, for primary prevention, statin use has been found to be less cost effective. The cost effective of intensive glycemic management with the goal of reduce our glycemic control depends on age and duration since diabetes diagnosis. Bariatric surgery was cost saving among individuals with type 2 diabetes and obesity, but only very cost effective among individuals with type 2 diabetes and overweight, likely due to largest health risk posed by obesity. And I would like to say this, that availability and affordability of pharmaceutical provision It's like part of university healthcare. But WHO is concerned that low and middle income countries have limited access to technologies and essential drugs for the treatment of diabetes. Drug for treatment of diabetes and related disease, glucose-lowering drugs, hypertensive and anti-lipidemic drugs are often unavailable and available only periodically, despite the existence of generics. In study covering 40 low and middle income countries, metformin and glibenclamide were able in only 65% of private or 50% of public health facility. It's not a good situation. But I would like to share with you some research which I made. Now I'm very interested in Pharmaco-economics, and they do a lot of research. Now I start about polyneuropathy, but now this is about availability of Ukrainian glycemic drugs for treatment diabetes. Most of Ukrainian med and foreign drugs are highly affordable but foreign medicine of modern drugs are moderately affordable, which does not contribute to use of modern treatment schemes. Because, you know, many people must, we have reimbursement system, but reimbursement system include only a few drugs like metformin and glibenclamide, and another, if you want to use another things, another drugs, you must buy this. And this is, I show that mostly the analysis show that in order to implement modern treatment scheme for type 2 diabetes, which according to currently legislation can be used in Ukraine, it is necessary to expand the list include in the reimbursement program. And this is, of course, increase our, improve our outcomes of treatment. Sorry. But main things, complication prevention and glycemic control are the most effective ways. Complication prevention and widely recognized as the most effective way to control diabetes treatment cost. And how we can this decrease, of course, is promote awareness about diabetes, promote lifestyle changing, patient education, adequate and appropriate management can prevent. But look, and also it's a lot of research show that big input of self-education increase cost of diabetes management. And there's an economic burden associated with therapeutic inertia. Look, we never thinking how it's big input on our economic burden. Achieve earlier in intensive glycemic control, thereby minimize therapeutic inertia, can lead to substantial saving for society, ranging between approximately 10 million euro till 50 million euro. You see, 1 or 7 years of therapeutic inertia. This study highlights that efforts on minimizing therapeutic inertia by securing timely intensification before individual target exceeded. Result is significant long-term cost saving. This is, we must be also remind all the time. And we, of course, use mHealth, decrease cost of treatment. If you see 55% hospitalization, we can decrease use this mHealth. But I know that India is super in this area. Many people take you like example, and this is, you can reduce. And telemedicine, of course, we can use, but anyway, we cannot forget about some people who cannot have not the skills, but telemedicine methods for monitoring diabetes issue are yet to find widespread use due to barriers, a lack of acceptance and double about effectiveness, availability, potential technical problem, and regulatory issue. And some medication adherence also, not from only, this is both sides, inertia from doctor, but this is adherence from patients. The annual, it's like 20% increase in adherence can save $100 in total healthcare expenditure for each patient with type 2 diabetes. As it is very important to educate patients that saving money today by not adherence to treatment may mean spending much more money in the future. I also make some research how cost this glucometer and checking monitoring is used only simple way by glucometer, but I think it's not extremely expensive. But people thinking that, oh, this is all the time expensive. But if you look on complication, how cost complication, it's impossible compare. This case, we also must deliver this message: invest in your health. And of course, globally, costs associated with medication errors had been estimated like 42 billion annually. This is, we also must remember about safely. And the clinical pharmacy, is my subject, but I will not spend a lot of time. But I'm sure that if you collaborate with pharmacy, it will be more effectiveness, because they will explain more slowly, and because this is them, and pharmacists can be assistant of doctor, and we can together reduce cost and also influence on outcomes. In this case, we must immediately action needed to stem the tide of diabetes and to introduce cost-effective treatment to revise these trends. Thank you very much for your attention. If you have questions, I will be happy to answer.
Thank you, Dr. Iryna Vlasenko, for your excellent talk. This is quite an important issue, and it varies from country to country in a huge way in this whole world. The economic, the cultural, the beliefs, the taboos, and the socio-economic placement of the patient and their family members are hugely affecting this, of which pharmacoeconomics is one of the great things that has to be solved out effectively by the stakeholders in different ways, and the government as well as the non-government organizations who are serving the society in a big way can help a lot. We are also very much in the process of implementing what you have said to remote areas of our vast country. And I sincerely thank you from myself as well as the others in the chair for your brilliant exposition of the issue. Thank you, Iryna, once again. Now, may I request Shashank?
Thank you so much.
Thank you.
Thank you, Professor.
Is Shashank there?
I think sir has some lost connection. Tripathi sir is there. Tripathi sir, if you want to make some comment?
Yeah, it was great and a very good presentation. It was very comprehensive. I must congratulate Dr. Iryna. It's a very important area. Yes, of course, the problem is compounding. Problem of diabetes mellitus is compounding definitely, but at the same time, if we think of the people who are suffering, people who either have been diagnosed or not diagnosed, who are having diabetes mellitus, how to reach out to them and optimize their care and treatment. Even when we are diagnosing, whether they are getting the right kind of treatment, and if not, why not? Whether it is the availability or lack of availability issue. You have rightly pointed out the access issue. Whether whether the right medicine is available at the right time, even if it is available, whether the person concerned can afford it. And you have shown some statistics that in private sector or even in the hospital, in the government hospitals, how the availability could be an issue. Okay, that you have shown. But I also feel that there is a need to generate data in this country also, in India also, like elsewhere. And India, we can understand it's a many countries within one country. There is a huge heterogeneity in the culture, affordability, language, practice, all together. So there is a need for generating data relating to pharmacoeconomics of diabetes management. Very much important. We all know recently we have published the latest version of the essential medicine list, and there are some 7 medicines, including some insulin preparations of for treating diabetes, as has been decided. Now, enlisting them in an essential medicine list is not just enough. That is the first step, primary step. But then to make these medicines, essential medicines, available to the people is important, and also whether they are available at affordable cost, affordable price. You have also mentioned about the generics and the biosimilar, generic chemicals as well as the biosimilars. Yes, until unless otherwise proved, we have to accept their quality. And but then, even whether, despite the fact that the generics and the biosimilars are relatively more economic, but whether our people, they can afford them. So it's a very important area, and we need to generate more indigenous data in these areas and convince our policymakers on one hand and the prescribers on the other. You have also mentioned, given the data of the economic aspect of of adherence, treatment adherence, how the treatment adherence or lack of treatment adherence can double the burden, economic burden. So that has also been shown. It's great to experience your presentation, and I hope that people like Dr. Shambho Samazdar and other clinical pharmacologists in India, they will take special interest in engaging themselves in relevant research to generate more relevant data for this country, and whereby looking forward that our patients would be better off with application of such evidences into practice. With these few words, congratulating Dr. Iryna again. We look forward to having more and more collaboration, academic collaboration with you. Thank you very much. Over.
I will be very happy to help you. This is also a new area for me. And as Shashank, remember, when I come to board, I say this is a pharmacoeconomic. It's a very important issue also for influence, and say Dr. Professor Apurba. It's very important, but this is gap. I can little bit explain 1 second that doctor, it's not for doctor, because doctor not work on this pharmacoeconomic. In pharmacists, it must be good collaboration. It will be super result, because you know exactly, you practitioner, you know what you use, and we know how we can collect account and something like that, and find better solution. I will be happy. Welcome.
Thank you. Thank you very much.
Thank you, madam. So may I request our chairpersons to please introduce our next speaker and the topic.
Dr. Anuj Maheswari is the next speaker, and he is widely known all over the country. He is the governor of the American College of Physicians India chapter, and he is a professor of medicine, HIMS Lucknow, and he has got tremendous efforts into the field of diabetes over decades. I know him sincerely, personally for a very long time. I know his sincerity as well as dedication to the subject of diabetes and the diabetic patients' plights. Without wasting any further time, let me request Dr. Anuj Maheswari to start his talk. He will be telling us about the management, the optimization of management of painful diabetic neuropathy in a diabetic subject. Thank you. Anuj, please.
Thank you, Professor Mukherjee, and it's really my pleasure that I am getting an opportunity to speak before you. And thanks to other respected chairpersons also for being here. So I'm sharing my slides. Thanks, Shambhu, for organizing this wonderful program on the platform of the Pharmacological Society. It's really a pleasure that Pharmacological Society is organizing such a nice program on rationality of the treatment and especially the pharmacotherapy for various aspects of the management of diabetes, including the cost effectiveness. Very nicely, my previous speaker has explained the cost effectiveness and its importance and how can it really be achieved in management of the diabetes. I shall be talking about the rational pharmacotherapy for painful diabetic neuropathy in next 20 minutes. So moving ahead in the direction, we all know about diabetic neuropathy is a loss of sensory function beginning distally in the lower extremities. That's also characterized by pain and substantial morbidity. Especially the pain is the most disastrous thing in diabetic neuropathy. Whenever a person gets neuropathy, it's the pain which brings him to the clinician. And this is a thing because of what is remains excessively perturbed. So multiple kinds of the diabetic neuropathies. We know about the large fiber neuropathy, small fiber neuropathy, proximal motor neuropathy, acute mononeuropathies, and entrapment. I'm not going into the details of this, all these varieties of the neuropathy, not in the pathogenesis of them, because my talk has to be focused on the pharmacotherapy, especially on the rationality of the pharmacotherapy. So moving ahead, giving an introduction of these various kinds of the diabetic neuropathy. As far as the epidemiology is concerned, India is ahead of all the countries in the Southeast Asia, which are having the diabetes and diabetic peripheral neuropathy. We are highest in the prevalence. As far as the pathogenesis is concerned, it is multiple pathogenesis are working together. Central and peripheral mechanisms of the neuropathic pain are working together in the patients of the diabetes, which is making their life more miserable. As far as the risk factors are concerned, in India, we find most of the time the neuropathy is brought by the angiopathy. Neuropathy is mostly caused by the vascular disorders, maybe the macroangiopathy, microangiopathy, for which multiple predisposing factors and triggering factors we all know. Apart from the sustained hyperglycemia, the most important predisposing factor, it remains there. We know about the abnormal immunity, which is very commonly seen in patients with diabetes. Recurrent infections are again another predisposing factors for with the sustained hyperglycemia, and many times these increase each other. Once there is sustained hyperglycemia, then tendency of the infections increases and immunity also jeopardizes. And in the setting of such kind of the situation, if it prolongs for sufficient time, then we find some triggering factors which makes the person into entrapped in this angiopathy, which is leading to the neuropathic illness. Like many a times we get the muscular atrophy, we get the foot deformity like clawed toes, hammer toes, Charcot foot. And the most important thing what we see in majority of the patient that they lost their painful sensation. And this is very commonly seen. Many times when the patient comes for the first time, the name diabetes, he is having some sort of the peripheral neuropathy. Skin atrophy, if it prolongs for a longer time, dryness of the skin also develops in due course of the time. Skin gets cracked, and these are the results of the autonomic dysfunction. And these are the factors which are more important, which triggers the symptoms and especially the pain in the patients with neuropathy with uncontrolled diabetes. How can we diagnose that? of course, there is a clinical diagnosis. What we can do is simplest method in our clinics with the Simmons-Winston microfilament test. But apart from this, or we can say in addition to this, we have got a lot of advanced techniques in our clinics which can be kept as a point of care testing methods for the diabetic neuropathy in our clinics, like Neuropathy, like pseudoscan, like nerve check, DPN check device. Multiple variety of the devices are there which can be kept in our clinics. Then we can move for the imaging. Imaging is a very important part, and which is a part of the advanced technology for the diagnosis of diabetic neuropathy, where we can see the nerve conduction testing. Then MR images can also help us about the neuropathy and foot which is being affected by the prolonged diabetic neuropathy. Leg Doppler test and vibration perception threshold is very commonly used method in clinicians' clinic most of the time. Obviously, without talking about the prevention, there is no rationality of the treatment exists. So diabetic neuropathy prevention is very much important, especially in the patient, those who have not yet developed the symptoms of the diabetic neuropathy. Always we should promote them for wearing the shoes all the time, taking care of their toenail. They should keep their dryness away. They should keep using the lotion for making it more and more wet most of the time, or moist most of the time. They should keep on checking their feet and legs daily if needed with the mirror under the sole. They can keep and they can check what is happening in the sole. Avoid standing up too long or too quickly on the foot. Don't walk on the bare feet, especially in the hot sun. So once we talk about the management, this management, the most important part of the management or any complications of the improved glycemic control. We cannot go away with that. So improved glycemic control is the most important and the foremost thing for diabetic neuropathy management also. Diet and lifestyle interventions and diet and lifestyle management are the most integral part of the glycemic control or glycemic management for any patients of the diabetes, may it be type 1, type 2, having neuropathy or any other complication. Then it comes for the relief from the pain, and with that we can use the disease modifying therapies also if they can improve in the progression of diabetic neuropathy. But again, I would like to say the biggest improvement we can get with good glycemic control sustained for a longer time. So once we talk about the uses of the etiological management and how to place the management therapies, then obviously the first management should be done at the end of the chronic hyperglycemia, which should be managed with best possible pharmacotherapy, may it be insulin or oral medication. Then many times we see that polyol pathway is the most important mechanism for development of the diabetic neuropathy. For that, we are having aldose reductase inhibitors in our treatment basket in the form of diaplaristat and sorbenil, which can reduce the nerve sorbitol for providing the relief from the symptoms. Then increased oxidative stress is one of the another important mechanism which leads to the symptomatology as well as pathogenesis of nerve damage. And there are the medications like alpha-lipoic acid and glutathione, which improves the oxygen-free radicals status, or we can say that reduce the level of the oxygen-free radicals and alleviates the symptomatology by interfering with the progression in pathogenesis. Then increased nerve hypoxia, which can be alleviated by improving the nerve blood flow using nitrates, ACE inhibitors, calcium channel blockers. Nerve degeneration can be corrected by using the nerve growth factor, ACTH analog, RHNGF, and they increase the nerve regeneration process, and increase advanced glycosylation end products are important thing which can give rise to the tissue damage if they are existing for a longer time in the setting of the sustained hyperglycemia. And aminoguanidine are the options available to us which can decrease the accumulation of the advanced glycated end products. So let's come over to the one by one on the options available to us. That aldose reductase inhibitors is a distinct class of the drug that interferes with the pathogenesis, prevent the formation of the sorbitol from glucose in nerve tissue, and prevents its consequences. Iplastat is the available option in our country for that purpose. Methylcobalamin is a long-lasting and very commonly used agent for the diabetic neuropathy. Many times we use it empirically also. It improves the symptoms related to the neuropathy like paresthesia, burning pain, increases synthesis of the lecithin, major component of the myelin sheath, and regenerates myelin sheath and thus protects nerve axons and peripheral nerves. So it is having excellent tolerability. Methylcobalamin is the active form of the vitamin B12, which is acting as a cofactor for methionine synthesis. So this is a thing with which we can regenerate the process of the demyelination, which has already occurred in a patient with diabetic neuropathy. There are certain evidences the using of the Iplastat. Multiple studies are there, 24 weeks, 12 weeks, and long-term Iplastat studies are also there, which have been found to be the delaying the progression of the diabetic neuropathy and ameliorating its symptoms, particularly in subjects with good glycemic control. So if we talk about the neuropathic pain, mostly it may be broadly divided into the focal neuropathies and diffuse neuropathies. So once we talk about the focal neuropathies, mononeuropathies are the more commonly seen, and we can see the symptomatic mononeuropathies, which can be alleviated with the symptomatic treatment. But on other side, we can also have the entrapment, and which may lead to the symptomatology and which may lead to the trouble to the patient already having the diabetic neuropathy. And in such kind of a patient, we can use the diuretics, splinting, lidocaine patch, surgical entrapment. And surgical unentrapment can also be chosen for the same. If we are talking about the diffuse neuropathies, obviously the proximal neuropathies and distal symmetric polyneuropathies, these two commonly seen. Once we talk about the proximal neuropathies, we can see the IV immunoglobulin and steroids may be the options, and treatment may be focused on the pain comorbidity. But once we talk about the distal symmetric polyneuropathy, we see a lot of inducing phenomena and pathogenesis are lying behind, like sleep disturbances, anxiety, autonomic activation, and depression. Depression is a thing which may be associated with symptoms of the depression, or sometimes it may not be very much visible with the symptoms of the depression, and simply patient presents with the pain. And we have seen that gabapentin, pregabalin are the molecules which also helps in sleep, but at the same time, they are also helping in the pain alleviation or reducing the perception of the pain. TCA contraindications, which are TCA and SNRI, are the mostly working as an antidepressant, and they alleviate the depression, but at the same time, they also give the relief in the symptomatic diabetic neuropathy. So pregabalin and gabapentin are anticonvulsant drugs that blocks the presynaptic alpha-2 delta voltage-gated calcium channels in the dorsal root ganglia. Serotonin and norepinephrine reuptake inhibitor, or SNRI, are duloxetine and venlafaxine. They amplify the activity of the noradrenergic and serotonergic neurons in the descending inhibitory pathways of the dorsal horn, suppressing the excessive nociceptive impulses from reaching the brain. SNRIs also exert an effect on the neuropathic pain through inhibition of the neuroimmune mechanism accompanying the nerve injury. TCA, as I already said, these are the antidepressants. They are very well in improving the symptomatology, They inhibit the presynaptic reuptake of the serotonin and norepinephrine, which activate the dissenting inhibitory pathways of the dorsal horn, suppressing the excessive nociceptive impulses from reaching the brain. Tapentadol and tramadol. Tapentadol exhibits additional norepinephrine reuptake inhibition, whereas tramadol exhibits additional serotonin and norepinephrine reuptake inhibition. It combines opioid and monoaminergic effects, represented a milestone in the evolution of the pain management. Given its mild effect on opioid receptors, tramadol induces fewer side effects than classic opioid. Tramadol produces satisfactory analgesia against various types of the pain, and it is currently approved for the treatment of moderate to severe pain. Thus, the combination of the monoamine and opioid mechanism opens new avenues for the designs of the innovative analgesics. Tropical capsaicin. Capsaicin is a natural alkaloid which is present in the red chili pepper and a selective agonist of the TRP1 receptor. Downstream signals from the TRPV1 receptors release substance P and other neurotransmitters. The repeated exposure to tropical capsaicin results in neurotransmitter depletion and a reduction in pain signals reaching to the central nervous system from peripheral nervous system. Tropical lidocaine, the drug is available as 5% lidocaine medicated plasters and is applied daily for 12. Up to 3 plasters can be applied simultaneously. It is well tolerated. Transient applications, side reactions may occur sometime, but they resolve with the removal of the application. When used as monotherapy, 5% lidocaine medicated plasters are associated with similar degree of pain relief, but with significantly fewer treatment emergent adverse effects when compared to pregabalin. Tropical glyceryl trinitrate and tropical chronic is used as an off-label treatment to alleviate the neuropathic pain associated with PDPN. The glyceryl trinitrate is proposed to act by alteration in neuronal nitric oxide synthase in the dorsal root ganglion cell and the spinal cord, contributing to the neuronal plasticity. Topical clonidine gel, an alpha-2 adrenergic agonist, has been shown to decrease by the Clostridium botulinum, and it blocks the acetylcholine release at neuromuscular junctions, causing muscle relaxation. The analgesic effect of the BTX is due to inhibition of release of neurotransmitter, including substance P, glutamate, and CGRP from the afferent nerves. So now talking about the novel pharmacological treatment options which are still under the trial or which are yet to come in the market, like sodium channel antagonists. We can also know about the sabinetide, which are the IRR, means innate repair receptors ligands. It is a novel peptide analog, the erythropoietin, and it acts by selectively interacting with the innate repair receptors. P2X3 receptor ligands are the selective antagonist that blocks the P2X3 receptor iliapixan, and the non-selective antagonist that blocks both P2X3 and P2X2 and CRs. This is the gefapixan, have recently completed phase 3 clinical trials for refractory chronic cough. However, these agents are potential drug targets for the management of the neuropathic pain. Vitamin D, we all know about the multiple benefits of the vitamin D, and one is that which is effective in the symptomatic relief as well as reduction in the pathogenesis or progression. It reduces the progression of the pathogenesis of the diabetic neuropathy. Its deficiency is associated with greater severity of the neuropathic pain in patients with diabetic neuropathy. Trazodone and gabapentinoid combination is a second generation antidepressant with a sedative effect. It has alpha-1 adrenergic, H1 histaminergic, and 5-HT2 receptor blocking action in the postsynaptic membrane at the lower dose. And it has serotonin reuptake inhibitory action in the presynaptic membrane at higher doses. Therefore, the mechanism of action is often referred as serotonin antagonist reuptake inhibition. A pilot randomized controlled trial showed a clinically significant improvement in the neuropathic pain symptoms with trazodone gabapentin combination. Dextromethorphan and quinidine combination has also been used. It is a sigma-1 receptor agonist, N-type calcium channel agonist, and serotonin reuptake inhibitor. There's a rapid and extensive metabolism by hepatic cytochrome P450 2D6, and at doses of 45 and 30 milligram or 30 to 30 milligram, the combination has shown its efficacy and safety for the neuropathic pain. So these are the chart which can give you an idea about the multiple options which are available and how do they work and what are the recommendations by various societies which are working for the diabetes management, including the ADA, IDF, for the recommendations of agents which can be used for the diabetic neuropathy. I think pregabalin is the choice given by almost every society. Diabetic neuropathy, a statement by the American Diabetes Association, that consider either pregabalin or duloxetine as the initial approach in the symptomatic treatment for neuropathic pain in diabetes. Various US FDA non-approved agents, including gabapentin or TCAs, can be used as second line. Given the high risk of the addiction and other complications of opioid is not recommended as a second line agent. Pregabalin is the most extensively studied drug by far in DSP, with majority of the studies being positive regarding the proportion of responders with at least 30% to 50% improvement in pain. And TCAs should be used with caution given the higher risk of the serious side effects. So key take-home message of the today's talk is that diabetic peripheral neuropathy is highly prevalent and disabling condition associated with significant healthcare costs. Currently, management mainly revolves around good glycemic control and symptomatic treatment of pain. Therapeutic options targeting root cause, underlying pathophysiology have not been sufficiently utilized. A lot of scope is there. Polyol pathway plays an important role in neurological damage in diabetic peripheral neuropathy. Aplaristat can inhibit polyol pathway and can prevent further neurological damage in diabetic neuropathy. Drugs like pregabalin, gabapentin are traditional anti-neurotherapeutic line treatment. Novel treatments have also emerged over recent time. Addition of methylcobalamin to aplaristat can have incremental neuronal and symptomatic benefits in diabetic peripheral neuropathy. Thank you very much for your kind listening. And this testing is the very important part of the treatment, and it must be continued in our day-to-day clinic. Thanks.
Thank you, Anuj, for covering this huge subject within the short period of time. So you have touched everything, almost everything available in the scenario of management of painful diabetic neuropathy. But it is an experience from my part, maybe discussed with you, that the polyol pathway inhibitor in the form of aplaristat, though has been used in very many patients, but the disease modifying effect that we expect from these agents, though costly, is not that much uniformly obtainable in our day-to-day practice. What's your experience, sir?
Yes, sir. In fact, I also realized that whenever I used these agents like aplaristat, initially it gives that its response is very slow. But once we are using it for a longer time, then we get the responses stabilized and it is staying with the patient. But all the time, problem is that we need to have the good glycemic control. But patient many times keeps waxing and waning the glycemic control. So whenever they are waxing, waning with the glycemic control, so we lose the improvement what we are achieving from these disease modifying agent, maybe aplaristat or anything else.
Otherwise, pregabalin and duloxetine, these are the most important symptomatic relief for majority of our patients, as enunciated by the authoritative bodies. But the scenario in the disease modifying agents, which can have a very significant long-term benefit, are obtunded by the failure to achieve and maintain good glycemic control throughout. So thanks once again. And I feel there are a lot of questions from the participants. May I request the participants to directly talk with Professor Anuj Maheswari, who is one of the doyen in the field. So you can have your opinion and questions directly to him. Anybody?
Iryna, you wanted to say something, I think.
Thank you very much. Brilliant presentation. I'm extremely happy with this and it's very informative. I know this subject, but I got a lot from you. Thank you so much. But from I have only one question about side effect, because mostly this is pregabalin, this is for symptomatic patient, painful. And how you can manage this side effect, because it's big influence on condition patient, and it's extremely, I see this like I cannot manage anything that is like influence. How it's not very often, but it's my experience. But how you manage this side effect, or what you can say this about this side effect?
Now you are talking about the triglyceride, I think so.
This is about pregabalin, gabapentin. If you use this,
TCA. Yeah. Yes. Actually, TCA is the most, we can say that, oldest armamentarium in our oldest tool in our armamentarium. TCA we were using for a longer time for the reducing of the perception of the pain. But now we have got better options than the TCA, then they are not so much used. But still, I find in my own patient, once the options which are modern options are not working enough, then TCAs work very well. And many times with a prolonged diabetes, there is some component of the depression also exists. And once you give the TCA, then it works on both the front. It reduces the pain perception. At the same time, it also reduces the depression component. And many of the times, if the patient is keeping his good glycemic control in those days, then TCA effectiveness improves with the tight glycemic control. So my experiences are very good with the TCA. I didn't find much of the side effects also in my patients with the TCA.
Okay, thank you so much.
So let me have a couple of moments. It was wonderful presentation. In fact, I'm Dr. Santanu Tripathi. So I was wondering whether I'm listening to a professor of pharmacology. Because this is primarily a platform of pharmacologists, so I'm sure the listeners, the audience, members of the audience will gain a lot listening to your presentation. It's very exhaustive. You have covered all aspects. It's important for the listeners, for the audience, that it is particularly to know that neuropathic pain, in most cases, the mainstay of management of neuropathic pain, all neuropathic pain, the classical analgesics, they have a very limited role. So you have to think of using the adjuvant analgesics, or the ones that have been mentioned by Dr. Anuj. But at the same time, I was just wondering, because Dr. Iryna is also there, that the problem of diabetic neuropathy and neuropathic pain, this is also an area which remains a little more neglected, I suppose, that yes, glycemic control remains the mainstay, but at the same time, the relief from pain is also important. And in many cases, the people do not get the proper relief from pain on one hand. On the other hand, there is also a lot of, we have seen that there are also a lot of possibility of inappropriate use of the adjuvant analgesics, unmonitored and inappropriate use, overuse, sometimes misuse. All these are also there. Side by side, what Dr. Iryna has mentioned about the adverse effect potential of these drugs, which itself will warrant more close monitoring, that many a times do not really happen. And that prompts us to also mention about or consider about the pharmacoeconomic aspect of treating or not treating, okay, or treating not so appropriately the diabetic neuropathy and neuropathic pain. So there's a huge area of pharmacoeconomic research, gap in pharmacoeconomic research in terms of management of diabetes complications in general and in particular diabetic neuropathy and neuropathic pain. So thank you again, and I congratulate you. Particularly, we will expect you in future sessions also of pharmacologists. It is a great awakening for all the pharmacologists also. I'll request our fellow pharmacologists to come up and generate data, do research in these areas so that we can have country-specific data to support our treatment decisions that we are otherwise are taken. Thank you very much again. I think there are a couple of hands. Dr. Shambho, you may allow our members of the audience to put their questions. Thank you. Over.
Hello, I'm Professor Lopamodra Chaudhary of RGKMC Medical College. Hope I'm audible. Hello.
Yes, you are audible. You are audible, madam.
Yes. Though the main therapy of neuropathy, diabetic, peripheral neuropathy is strict diabetic control, glycemic control. And that's the main, but to relieve the pain, I've seen that gabapentin and pregabalin are most commonly used. But here, it was a very informative session, a presentation, very nicely said. And I just wanted to know the recent advancements. I mean, though this gabapentin and pregabalin are being used in addition to antidepressants, yes? So which is most recommended? From this presentation, I come to know that this apelristat and methylcobalamin or this newer agents, they are being much more advised. Which is most recommended in relieving the pain?
Yes.
There are so many.
Should I answer this question?
Yes, yes.
Yes. So thank you, Dr. Lopamudra. I was just reading your comments in the chat box also, what you have asked that of course, with all the organization and all recommending authorities are recommending the pregabalin as the number one for the alleviation of the pain. And duloxetine comes after that. And gabapentin can also be used. In fact, you may be knowing that gabapentin and pregabalin are the same class of the drug. So if you are not getting the benefit and not getting the response of pregabalin, it's rarely seen that gabapentin will do work. But many a times, if you are using both together in the recommended doses, within the profile of the recommended doses, then probably sometimes you can get the benefit. But most of the time, once the advanced diabetic neuropathy is there, then things becomes very individualized. And we have seen that some of the patients are responding with one particular medication very effectively as compared to the another one which is largely recommended even. Apularistat kind of the things usually don't work once the patient is having excessive symptoms or it seems that it's not working. Although they keep on working because they are the disease modifying agents, they help in reducing the progression of the pathogenesis of the diabetic neuropathy. But until unless you won't give the relief from the pain or relief from the symptom, patient won't remain satisfied. And he will not think that you are doing the correct treatment of that. So this is the barrier which comes up in the uses of apularistat kind of a thing. Methylcobalamin is not yet recommended by any organization as a sole agent to use for neuropathy, but we see in some of the patients it gets good benefit, especially in India, where we see that vitamin B12 deficiency is very commonly seen and it is associated with the demyelination. Then methylcobalamin works good whenever it is supplemented, and remyelination process and repair of the nerve tissues becomes faster when the methylcobalamin is there. But still we are waiting a largely accepted data. Hope it works. My answer works, Dr. Lopamudra.
Yes, yes. So let me profusely thank Professor Anuj Maheswari for his beautiful exposition of the subject and almost touching everything associated with the management of painful diabetic neuropathy. I thank you very much for your enthusiastic participation and covering almost everything within the short time allotted to you. Thank you, Professor Maheswari, once again. We are proud that you are now the governor of the American College of Physicians India chapter. So we all thank you sincerely for making this Pharmacological Congress or e-Symposium a success. So we have to move forward, and let me invite our next speaker, Dr. Shambhu Chaudhary, Shambhu Majumdar. And Shambhu Samaj Majumdar is a brilliant clinical pharmacologist from this part of the country. He has also, Shambhu Samrat Majumdar has dealt with in the Epicon 2023 at Ahmedabad. And you must be knowing that the topic which was given to Professor Anuj Maheswari is quite an exciting topic and a very rewarding topic, and a topic that brings the patient to the doctor earliest. The neuropathy associated with diabetes might not be associated with that much of pain. Pain brings the patient early as compared to anything else, so that you can embark upon a good glycemic control associated with the drugs to achieve unique benefits for the relief of pain and education to the patient about the significance of good glycemic control. But many of the patients might not have pain, and this insensate food is one of the very important predisposing harbinger of diabetic foot disease. If the patient has got painful diabetic neuropathy and we are enthusiastic enough to jump upon the patient to relieve the pain, to educate the patient about good glycemic control, educate about prevention strategies of different foot lesions, we can achieve many things over a period of time ahead to the patient. But next speaker, Dr. Shambhu Samrat Majumdar, will be telling about a very silent killer in association with neuropathy in most of the situations, because autonomic neuropathy is mostly a part and parcel of peripheral neuropathy. And once you get peripheral neuropathy, you are bound to examine for autonomic neuropathy, of which cardiac autonomic neuropathy is one of the most neglected one. But let me remind the audience that cardiac autonomic neuropathy is the most significant killer of amongst the neuropathy complications of diabetes, which is often ill understood and ill evaluated. And Shambhu is going to tell us about cardiac autonomic neuropathy detection, particularly while you are treating a patient of diabetes, and particularly patients having peripheral neuropathy with the monobilum test or a deep tendon jerk response, or there is some foot deformity, then you get that the patient has got motor or sensory or some neuropathy in the feet. But it is a bounden duty on the caregiver parts to unveil cardiac autonomic neuropathy. Without wasting any time, let me request the renowned and brilliant clinical and pharmacologist from this part of the country, Dr. Shambhu Samrat Majumdar.
Thank you,
Please.
sir. Thank you very much for wonderfully setting the stage on this very important topic on cardiac autonomic neuropathy detection. So at the onset, I want to thank Professor Anuj Maheswari sir and Professor Iryna madam for having those two brilliant lectures. And also what I want to acknowledge in the beginning of this presentation on cardiac autonomic neuropathy detection, I was just revisiting 12 years back when I was an intern. I was roaming behind Professor Apurba Mukherjee sir in the ward because we all want to learn something from the sir. And one statement had been made by Professor Mukherjee sir towards his postgraduate student that please learn about this diabetic autonomic neuropathy, because if you want to be master in medicine, clinical medicine, you have to be master in diabetic autonomic neuropathy. So diabetic autonomic neuropathy is such an important topic which covers everything, every aspect of clinical medicine. And also I am really thankful to Professor Apurba Mukherjee sir because he had written a chapter on API update in 2016, which is still available in net. And I had learned from that chapter about this topic. And it is a really proud moment of mine because sir is now the chairing the session and I am going to discuss about this topic. And we have Professor Santanu Tripathi here. Sir had initiated this specific dysautonomia clinic in the clinical pharmacology OPD of School of Tropical Medicine, where he had taught us how to do this clinical testing manually. Now we have machines also to support this testing, but Professor Shantanu Tripathi sir had taught us how to detect it manually with just a BP cuff, with just a continuous ECG monitoring. How can we monitor? How can we detect cardiac autonomic neuropathy early? So for next 20 minutes, I will try to cover this 4 agenda. That is, first, a basic understanding of autonomic nervous system. Then why diabetic autonomic neuropathy screening is important, how to detect cardiac autonomic neuropathy clinically, and if time permits, we'll discuss about a case study. So life is all about balance. Balance is something we all want. And homeostasis means it is a dynamic balance between the autonomic branches, the sympathetic and parasympathetic nervous system. And we all know that all the physiological markers are generally a product of this balance between parasympathetic nervous system activity and sympathetic nervous system activity. So when go through the anatomy of craniosacral outflow, that means the parasympathetic outflow, we all know the preganglionic fibers are larger compared to the postganglionic fibers, and that is why the parasympathetic nervous system dysfunction occurs early compared to the sympathetic nervous system dysfunction, because the sympathetic nervous system, the preganglionic fibers are shorter. This picture beautifully describes the anatomy of autonomic and autonomic nervous system, both the sympathetic and parasympathetic nervous system. So just I want you all to close your eyes and think that in front of you, this beautiful animal is present. Yes, in front of you means if it is in front in the screen, then it's fine. But you just think it is physically it is present, not in a virtual mode, but the physically mode. This beautiful leopard is present in front of you. So what happened inside you? That is the thing done by your sympathetic nervous system. And now assume that you are in the position of this beautiful animal and he is, or you are eating your prey. And after eating your prey and you are resting. So everything now inside your system happening is due to the parasympathetic nervous system activity. So this is the rest and digest system, the parasympathetic nervous system, which promotes digestion, GI peristalsis, slows heart rate, constricts pupil, empties bladder, relaxes sphincters, mediates genital erection. And when we are talking about sympathetic nervous system, this is the fight and flight system, which actually activate our body. That means increase heart rate, increase sweating, dilates pupil, inhibits GI movement, and closes all sphincters, diverts blood from skin and GI tract to skeletal muscles. They mediate genital ejection. Ejaculation is mediated by sympathetic nervous system, whereas the parasympathetic nervous system mediates the erection. So when we are talking about sympathetic and parasympathetic nervous system different activity, I think this is the beautiful diagram which explains all the mechanism done by sympathetic and parasympathetic nervous system. You can take one snapshot and I think you can use it in later. So now our topic is why this screening is important, why we should go for diabetic autonomic neuropathy screening, or more precisely the cardiac autonomic neuropathy screening. Unfortunately but true, there are lots of prevalence studies have been conducted, but due to different variation in the sample size, the prevalence varies from 7.7% to 90% in type 1 diabetes. So we have some lacuna in the research on prevalence itself of diabetic autonomic neuropathy. Even in case of type 2 diabetes, we can see the prevalence varies from 20% to 73%. So what are the major risk factors behind this diabetic autonomic neuropathy? Like all the micro and macrovascular complication, the most important risk factors are the A1C, the blood pressure, the cholesterol or lipid load, and the duration of diabetes. So this ABCD is important risk factors. What Professor Apurba Mukherjee sir has told beautifully, the most important point we all should remember, the subclinical autonomic dysfunction, which is very common, and symptomatic autonomic neuropathy that happens after long time after the onset of diabetes. So we should not wait long time to develop the symptomatic autonomic neuropathy. We need to detect those subclinical autonomic dysfunction. Why? Because 25 to 50% die within 5 to 10 years of diagnosis. And 5-year mortality rate is almost 3 to 5 times higher. I think we need to remove some annotation. Yeah. So can you, Rohan, can you help us to just omit those annotation in the screen? Rohan, are you there? Could you please remove those annotation? I think, yeah, okay, no problem. So 5-year mortality rate is 3 to 5 times higher if the cardiac autonomic neuropathy is present. And we can see there are different studies which suggest the relative risk of mortality in diabetes patients with cardiac autonomic neuropathy is almost 4. And what is very important to note, because lots of our patients will come to us with diabetes to having the pre-anesthetic checkup. So operative fitness they want, anesthetic fitness they want. But in presence of cardiac autonomic neuropathy, there is an increased risk of morbidity and mortality. One important parameter we all now know, specifically due to the availability of ambulatory blood pressure monitoring, if we can detect the non-dipping or reverse dipping blood pressure in diabetes, that means the normal dipping is between 10 to 20% should be dipped when we are sleeping. But if that is not happening, non-dipping, that means from below 10% of dipping. So that is actually 0 to 10% is non-dipping or reverse dipping. So instead of going down, the blood pressure rises. So that is a very important risk factor for left ventricular hypertrophy. or sometimes 2 to 8-fold increase in risk of cardiovascular and renal events. So when we are talking about diabetic autonomic neuropathy screening recommendation, the American Neurological Society has a very clear-cut guideline. They recommend to screen for autonomic dysfunction immediately after the diagnosis of type 2 diabetes. And in case of type 1 diabetes, the screening to be repeated 5 years after the diagnosis. And testing should be repeated yearly if CAN testing comes normal. If abnormal, more frequent checking is required. And when we are talking about operation, so before going to undergo general anesthesia, this test should be done, because we need to explain the prognosis to the patient. And also, if in presence of cardiac autonomic neuropathy, the intensified exercise may lead to sudden cardiac death. So it is better to go for cardiac autonomic neuropathy screening before recommending any exercise protocol. So how we can detect? Again, the 3 important pillars of detection, and most importantly in the history, they emphasize, our teachers emphasized on history taking. But here the clinical methods are very important. Why? Because most of the cases are subclinical, and we need to detect them in a subclinical stage so that we can prevent the progression, and some lab results. So this is why the clinical sequel signifies why we need to go for cardiac autonomic neuropathy even the patient does not have any symptoms. So heart rate variability test simply can detect any parasympathetic dysautonomia. So this is one form. This has been actually prepared by my guide, Professor Santanu Tripathi sir. I'm just quickly going through this form, which is now we are doing also in our lab in the clinical pharmacology OPD. So these are some history taking points are there when the patients visit our OPD. And this is the questionnaire for IIEF5, from where we can have some idea on erectile dysfunction. And if the score is high, then it's okay. But if it is low, then we should also go for erectile dysfunction related pathology screening. And these are the important data which we measure. I'm just in the protocol itself. So when we are talking about autonomic investigation, there is some conventional method like Ewing's protocol. Some lab tests are available like Skarmer's test, pupillary function test. Overall, the autonomic neuropathy can be tested through that. Some pseudomotor test, plethysmography, thermoregulatory test, or some specific imaging studies and exercise tests are available. And also some sensitive variability assessments through heart rate variability and some blood pressure variability, baroreceptor sensitivity testings are there. But for all practical purpose, the Ewing's protocol is very simple and it can be done in OPD-based clinics. So in case of, if we just follow the Ewing's protocol, what we need some clinical expertise on having a heart rate monitoring, and continuous ECG can help us to have that heart rate measurements and also the blood pressure measurements. So we need to see the response at rest and after various maneuvers like normal breathing, deep breathing, Valsalva maneuver, changing in the posture, and some isometric contraction, the delta diastolic blood pressure can be measured. So when we are detecting cardiac autonomic neuropathy, first of all, we need to check the resting heart rate. If it is more than 100 beats per minute, there is something abnormal. Bit-to-bit heart rate variation can be observed through ECG. Patient should abstain from drinking coffee overnight and test not performed after overnight hypoglycemic episodes when we are talking about cardiac autonomic neuropathy. Then when we are talking about to check the expiratory inspiratory RR ratio, then we need to ask the patient lying supine and breathing 6 times per minute. So if there is a difference in heart rate less than 10 beats, that is abnormal, because we all know with inspiration, heart rate increases, with expiration, heart rate goes down. But if that is not happening, if that inspiratory heart rate and expiratory heart rate has a difference below 10 beats per minute, that is abnormal. And when we are talking about RR ratio, then expiration, inspiration, RR ratio, if it is less than 1.17, again, this cutoff is age dependent. We can see here, there are lowest normal value as per different age groups. So if it is less than the cutoff, then that is something abnormal and parasympathetic nervous system affected. Another is the Valsalva maneuver. The patient forcibly exhales into a mouthpiece of a manometer, exerting a pressure of 40 millimeter of mercury, 15 seconds. The nose should be blocked by some clip. If the ratio of longest to shortest RR interval is below 1.2, that is abnormal. And if the RR interval is measured at beats 15 and 30, then this 30:15 RR interval ratio, if it is less than 1.03, that is also abnormal. Now coming to the sympathetic nervous system testing. And for that, the hand grip test is very easy. The diastolic blood pressure response to isometric exercise. Patient squeezes a hand grip dynamometer to establish his or her maximum effort. Then we need to ask the patient to squeeze that same grip at 30% of the maximum for 5 minutes. If there is a rise more than 16, then it's okay, it is normal. But if it is less than 16 in the contralateral arm, so that is abnormal. A very simple mental arithmetic challenge can be done to assess the sympathetic nervous system function. So we can ask the patient serially subtraction, aiming to activate the sympathetic outflow. If there is a subsequent increase in systolic blood pressure, more than 10 millimeter of mercury, then it's normal. If it is not, there is some problem. So in nutshell, the different parameters we can see from this slide, what is normal, borderline, and what is abnormal. Again, the expiratory-inspiratory ratio, RR ratio, that is mostly age-dependent cutoffs are there. So we need to follow that. When we are grading cardiac autonomic neuropathy, the Toronto Diabetic Neuropathy Consensus Panel, they had made a clear-cut guideline on that. So presence of one abnormal finding indicates a possible CAN. At least 2 abnormal finding confirm CAN. And in presence of orthostatic hypotension, we can call it as advanced CAN. But Ewing et al. Proposed a very popular classification like early involvement, definite involvement, and severe involvement. So early involvement means 2 borderline test results or 1 abnormal result on heart rate variability test, 2 or more abnormal results on heart rate test, that is the definite involvement, and severe involvement means development of orthostatic hypotension. There is now coming a short-term ECG recording, which also gives us a clear picture on sympathetic or parasympathetic dysautonomia. This is analyzed by a dedicated software in the frequency domain. Fourier method was utilized to transform those RR interval into waveform, and that waveform becomes three basic components. One is VLF or very low frequency. If it is less than 0.04, that's okay. The low frequency, LF means between 0.04 to 0.15. Actually, the low frequency denotes the combined effect of sympathetic and parasympathetic influence. And high frequency, they are signifying the vagal activity only. So decrease in HF value is a sign of parasympathetic dysfunction. So in case of early stage of autonomic dysfunction in diabetes, we found sympathetic predominance. So the LF, that means sympathetic plus parasympathetic. So LF by HF, as HF is only the parasympathetic activity. So LF by HF ratio increased. But again, the Ewing test is simpler. We can do it in a clinic basis. A small, I will rush through this case. This is a 56-year male, type 2 diabetic for 15 years, having some symptoms suggesting of diabetic neuropathy. And this is the medication we can see on premixed insulin, vildagliptin, metformin, atorvastatin, amlodipine for neuropathic pain. He was on amitriptyline, vitamin B12, CBG was checked. There was a 56 milligram per DL. It was noted in his prescription without any symptoms. So hypoglycemic unawareness is there. And we all know that with hypoglycemia, there is an autonomic failure that happened. So history of pre-lunch severe hypoglycemia and 2 episodes of hospitalization also there. These are the current concerns like fall, pain abdomen, which increased after eating, bloating, and fullness of abdomen. All these symptoms are suggestive of diabetic autonomic neuropathy. So the patient was referred to our clinical pharmacology OPD by the diabetes clinic in School of Tropical Medicine, and we assessed those patients. So this was some examination point. The retina was normal, though there is no diabetic retinopathy, but you can see there is development of severe cardiac autonomic neuropathy. So all these are the lab results. We can see the vitamin B12 is normal. There is left bundle branch block, IIF score that is very low, below 10. And when we are talking about the different findings, there is a parasympathetic nervous system dysfunction as suggested by Valsalva ratio. And also there is some dysfunction in terms of sympathetic nervous system activity, because we can see the post-hand grip diastolic blood pressure difference was delta TBB was only 6, but there is no orthostatic hypotension in this case. So we had adjusted the insulin dose specifically in presence of diabetic autonomic neuropathy who has symptoms suggesting of gastroparesis. We are using mixture 30-70. So instead of using it 30 minutes before meal, we need to advance it, and we just tell them to take this mixture 30-70 before meal, just before meal. So though this should be ideally done through the checking the gastroparesis component of that patient, but it is not available in our setup. We advise to check CBG frequently. We omitted these drugs like vildagliptin, amitriptyline, because the amitriptyline, we all know, it has a high anticholinergic burden, which may promote more parasympathetic dysautonomia. We continue the other medicine. Just I am going, this is an anticholinergic burden scale. You can see the amitriptyline has very high anticholinergic burden score. And after 3 months, this is wrongly written. We had done it after 6. These results are after 6 months. I'm sorry for this mistake. The Valsalva ratio was improved. Deep breathing, inspiratory expiratory ratio was becoming normal. And also the post DPP, which was initially 6, it becomes 10, though it is not more than 16, but it improves. This was actually, we had published in JIMA. Very recently, we had done one study to find out the polypharmacy, cardiovascular autonomic function among the elderly patients in urban municipality area. We had done this study to find, and it was surprisingly found, we found that polypharmacy was significantly associated with cardiac autonomic neuropathy among the community dwelling. And it was found those patients who are having polypharmacy, they have also a very high anticholinergic burden. So this is an area we need to explore more. So coming to the final slide, the diabetic autonomic neuropathy is the common and serious complications. We need to acknowledge that. And for that, we need to early detect the cases and start treatment promptly. And the management is very simple. The overall principles of managing diabetes need to be followed, starting from the A1C control to blood pressure control to cholesterol management to diet to exercise to follow up reconciliation and food care. F for food care also. The G for we need to acknowledge the glucagon axis too when we are managing this, because there are some studies which suggest the glucagon axis modulation can help in prevention or delay the development of autonomic neuropathy. We should be very careful regarding the hypoglycemic events, and I is very important here. That is the insulin. When we need insulin, we need to start insulin in the correct time. Thank you once again. If there is something to discuss more, and I must request Professor Apurba Mukherjee sir.
Thank you, Shambho.
Thank you, sir.
Thank you very much for your excellent talk. And I want to emphasize what you have said in a very beautiful fashion, that this is one of the very neglected area of evaluation of a type 2 diabetic patients, which is the majority in our centers. And many of our people suffering from diabetes for 15, 20 years are found to have cardiac autonomic neuropathy, and it is almost a practice by the ordinary caregiver to see orthostatic hypotension as a part of cardiac autonomic neuropathy. But you have beautifully highlighted that orthostatic hypotension comes much later. And we need to unveil the people who are not having symptoms of cardiac autonomic neuropathy. What is very, very important to realize that this is one of the very, very significant contributor of cardiac mortality, and patients who is having cardiac autonomic neuropathy do die within 3 to 5 years of their diagnosis. If not, they are treated very, very effectively. And while you were presenting your slides, which must have struck all of us, is the polypharmacy as an important contributor to aggravation of symptomatology as well as the pathophysiological defects associated with cardiac autonomic neuropathy. We have seen people having sinister arrhythmias who were previously having pre-existing coronary artery disease with myocardial dysfunction do tend to develop very sinister type of cardiac arrhythmias in the form of ventricular ectopics, tachycardia, and fibrillation within no time. And that's the most important cause of death in very many of them. Erectile dysfunction is not a significant component of cardiac autonomic neuropathy, but anybody and everybody coming to you with sinister erectile dysfunction, you need to evaluate neurological disorder in them as the cause of it. And if it is so, then unveiling cardiac autonomic neuropathy is an important task on the part of the caregiver. So I profusely thank Dr. Shambhu Samrat Samazdar for elaborating such a very, very important topic and giving it a place in today's symposia, e-Symposia organized by All India Pharmacological Society as well as the Pharmacological Society of West Bengal chapter. And I know the brain behind it is Professor Santanu Tripathi, and I profusely thank him for the same. There might be some questions from or comments from anybody else. So let it be started. This is my request.
I
that
think,
it may start.
I
Yes.
think, sir, I am remaining. So as Dr. Mohan Sinha has already joined, let's start his presentation. We can address those questions at the end.
All right, all right. So may I invite Dr. Mohan Sinha, who is one of the very important personality in the field of endocrinology. He is working as the professor of endocrinology at Sri Gokulam Medical College and Research Foundation. And he is going to tell us about the primary prevention with aspirin in diabetes. That is one of the important area and the current understanding. I know there are recommendations by American College of Cardiology and American Diabetic Association about the aspirin in primary prevention in their population. And they have categorized that below 40 years, they should not be given. And if there is not more than 2 other risk factors, cardiovascular major risk factors, this should be avoided. But in a country where diabetes occurs at least 1.5 decades or 2 decades earlier, as compared to Westerners, and the people who are succumbing to a acute myocardial event, can this primary prevention with aspirin in type 2 diabetics of South Asian population, and particularly in India, where it is not uncommon to see patients having double vessel disease or triple vessel disease below the age of 40 years, suffering from diabetes for 10 years or 12 years. So it's a very important issue that has been placed in today's symposia. And I firmly believe that Professor T. Shenoy from Venjarakudu, Kerala, as the medical college is situated there, is the Sri Gokulam Medical College and Research Foundation. And he will be taking us through this very exciting topic. Dr. Mohan Sinha, please.
Can you hear me? I hope you can hear me.
Yes, Dr. Mohan Sinha, please.
Yeah, thank you. Thank you. Thank you, Pharmacological Society of Bengal, for giving me this opportunity. Without much ado, I would like to go ahead with my presentation. So my topic over the next 20 minutes will be spread across 3 basic headings. The first regarding what this topic holds in our current evidence-based medicine setup, and what are the guidelines which are going to be discussed in the next few minutes. So as you have seen, diabetes has treatment has actually changed in the last several decades. You can see that 2008 till that time, HbA1c was the major player. So HbA1c was the only thing which usually guided us in treatment management. And we see that HbA1c lower the better was the principle mentioned. From 2008 onwards, the guidelines have been more towards so many other players. So weight gain, hypoglycemia, the side effects of diabetic medicines like the glitazones, that rosiglitazone episode had come in that year. From that time, it was believed that HbA1c, the lower the better, but without complications and side effects of that. And finally, from the last 10 years, we can see, or last 7 to 8 years, we can see that with the advent of the gliflozins, we have seen the cardiovascular risk factors, also GLP-1 agonists. We have seen that blood pressure, LDL cholesterol, the glucose lowering agents have definitely come up with the better ideas. So we can see that diabetes is a chronic metabolic condition with hyperglycemia, with other complications. And there are so many different players involved in this. We can see that the genetics, of course, is important. The sleep pattern is important. The weight gain, obesity is a major issue. We can see the poor heart, the vasculature, the pancreas. These factors definitely are important to control the long-term efficacy of the medicines as such. So in this particular topic, we are going to discuss regarding the age-old medicine called aspirin or acetyl salicylic acid. So we can see that in this graphic cartoon, we can see that inflammatory pathway is one of the major players in this diabetes pharmacology, and we can see oxidative stress,
endothelial dysfunction, insulin resistance, and progression towards atherogenesis are relentlessly producing in diabetes, independent of the progression of the disease as such. And that is the reason why risk factors have to be addressed in the primarily aspect as such. So several prospective studies have shown that poor glycemic control is a major causative index in the microvascular disease, whereas macrovascular or the heart, the CNS, we can see it's a complex phenotype, which means that we have to manage by dealing with the risk clustering or risk side effects. So the definition of primary prevention is that the person does not have any clinical symptoms as such, and guidelines are designed to control the first or prevent the onset of the first myocardial infarction, the stroke, the heart failure, and the atrial fibrillation. So this is what this topic deals with. And we can see the publication from Lancet shows that compared to non-diabetic individuals, the diabetic individuals have at least one earlier decade onset of all these side effects. And we can see the cardiac the profile of these include the peripheral artery disease, the heart failure, the stable angina, the non-fatal MI, the stroke, which is the major adverse cardiac events. And definitely it appears a decade earlier than the non-diabetic individuals. This is the reason why we should prevent these risk factors to be manifested. This includes smoking, high blood cholesterol, the obesity, physical inactivity, the high blood pressure, as well as the diabetic complications. We can see that the risk factors we cannot control are the hereditary risk factors, the previous history of attack or stroke, the gender is itself, ethnicity, and the age. So coming to our topic per se, aspirin is an agent which has been hailed as the wonder drug, and the story decades as early as 2,500 years back, when willow bark was used as painkiller and antipyretic by Hippocrates and other scientists. So it was used as an antiplatelet drug as early as 1960s and 1970s. And since then, low-dose aspirin has been used in cardiovascular protection studies by involving more than 200 studies by including more than 200 million populations. So you can see aspirin mediates the antithrombotic effect to inhibition of platelet aggregation, and it does by cyclooxygenase COX-1 inhibition and to cyclic prostanoids like carboxyl A2, prostacyclin, and other prostaglandins. And because platelets have got minimal capacity for protein synthesis, inactivation of COX-1 by aspirin is irreversible for platelets, which means that the half-life of 8 to 10 days may be effective. So the low dose will definitely address this side, which is the thromboxane A2. Higher dose will definitely address the anti-inflammatory pathway. So basics of diabetes, we can see that type 2 diabetes includes the endothelial dysfunction, so many risk factors like von Willebrand factor, TP, adhesion, follicles, oxidate. So we cannot measure these in ready-made, which is why HSCRP, IL-1, IL-6 has been used, as well as insulin resistance using the HOMA, beta, HOMA IR studies. Dyslipidemia is one of the major issues with diabetes, and it is independent of the diabetes as such. So this is why the hypercoagulability also has to be addressed. So let us see the first studies which has been published in the primary prevention aspects. So this we can see the slide focusing on the risk factors in the last several decades. Till 1990s, we can see that there was a British male doctor study and focused on male physicians in UK. The major cardiovascular events were captured, 5 years duration, and we can see odds ratio of 0.98. Because we are discussing today with the pharmacologist in the major audience, we can also see that the physician's health study was the largest study, which included the Peto et al. Also the thrombolytic studies. So you can see that fatal and non-fatal MI was the major primary endpoint we studied, nearly the same years, but you can see the large population number was recruited. That is, 22,000 patients were recruited. Odds ratio was 0.56, which was very showing that risk was controlled. And similarly, so many studies like the hypertension observation study was done. So these are the studies which are published, which included the women's health study, which included female health professionals from US. So we can see that these studies are the landmark studies for the primary prevention and pivotal studies for aspirin used. So as the decade went ahead, we can see the other risk factors were studied, and the systolic blood pressure progression and 10-year cardiovascular mortality and across 1,000 patient years was recruited. The presence of diabetes was the major risk factor in dictating the progression, and we can see compared to the non-diabetic individuals, the cutoffs for the blood pressure and the cholesterol were definitely higher. And the Naveed Sattar group had mentioned that it assumes the cardiovascular health disease equivalent threshold once the diabetes duration goes beyond 10 years. So this is why a duration of 10 years was considered to be a cardiovascular risk, because beyond that years, we can see the risk factors are progressing. So last few years, last 2019 onwards, studies have focused on multinational observation cohorts, and you can see all-cause mortality and all-cause disease were effectively controlled by adding agents, which was timely and early. And this is by diagnosis of diabetes at age of 45 years, by itself reduces the lifespan by around 6 years. This is what the studies have focused. So cardiorenal outcomes were benefited by giving early treatment and primarily. So coming to the aspirin, so the initial studies were on only the observational data and not based on many major studies. So that is why the initial trials were not very robust. So the first trials in diabetics were the JPAD and the PAPA-DAT, and these are focused 2008 onwards. So from that years onwards, the FDA advisories were coming to being, and the European Society of Cardiology also had a proper guidelines coming up. So we can see as time went, the bias studies were also identified, the non-diabetic studies were also highlighted, and with this we have found that effectiveness of aspirin was also found, and in the US FDA studies also. So we have to see the ASCVD risk calculator also. So if you can see this slide over the left side, you can see that the gender, the age, the race, the cholesterol total value, HDL cholesterol, the systolic blood pressure, hypertension, and diabetic status, including smoking, was also captured. So this is a ready-made, handmade app. You can see that all the phone, all the devices have this. So even in a busy clinic, we can calculate the 10-year ASCVD risk, also the lifetime risk for the cardiac events also. So with this, we can see that the progression towards diabetes and the complication has been identified. So I'll just share the screen once more. 1 second. Yeah. So now you can see that very high risk factors, we can see more than 15% risk factor. So which means that.
Sorry, Dr. Mohan, actually the screen is not shared. So can you please?
Okay. I should have shared once more. I was asking that same question. Yeah. Should I start again?
Yes, please share the screen.
I was thinking that the screen was visible, so I was asking that same thing. Yeah, so I'll just share once more. Yeah. So you can see the slides now?
Yes, now it's fine.
So I was asking the same question initially, so I think nobody had told me. Thank you for that.
No. Yeah. Initially it was there.
Okay. So till which slide was that visible? Till what slide you heard?
You move on.
This slide was seen?
You move on, yeah.
Had you seen this slide?
No, from this slide only.
Okay, sorry. So you can see that the major cardiovascular risk studies were captured, and you can see the publications were varied. And from the last 2 decades, you can see so many guidelines were also coming into the practice. So initial studies on aspirin were focused on the ADA and the AHA, the guidelines, and that was actually not based on any major trials done in diabetic population. So the 2008 onwards, the diabetic studies were recruited, and 2008, you can see the JPAD study and the PAPA-DAT studies were published. So after that, the technology studies were also there. So non-diabetic studies were also recruited. So there was an attempt made by the scientists to get through the cardiovascular risk profile in the diabetic individuals as such. Meanwhile, the FDA advisory also came in. So multiple meta-analysis also came in. The review studies were published. So systematic reviews were the highest, and meta-analysis were also the highest evidence available. So that time, definitely the risk for aspirin, like the bleeding risk, the risk progression, and the side effects were also captured in those studies. And finally, the JPAD2, the unbiased version, also came by. So this is the reason why the ASCEND, the ARRIVE, and ASPRI, the elderly by the ASPRI studies. ARRIVE was focused on the intensive risk, and also on the diabetic population, ASCEND study, the primary prevention. So ASCVD risk capturing, this is the major tool used in our diabetic individuals. So the 10-year risk of ASCVD risk was captured. So this is how you calculate the progression, the male gender, the race, the age group, the diabetic presence or not, the smoker. So these are the ways in which the primary prevention or secondary prevention, the statins or other agents addition has been dictated. So these fields have to be completed. And this way, the absolute risk for 10-year and lifetime risk are captured. And the low risk means 0 to 5%. The borderline risk means 5 to 17, 7.5. Intermediate risk means 7.5 to 20%. High risk means more than or equal to 20%. So in this, we can see that it is coming to the nearly the high risk, but it's in the intermediate risk, which is why we should definitely use this in our practice. And this includes the racial classification also. So you can see here the high risk also includes the target organ damage, the presence of early onset type 1 diabetes of long duration, the duration of type 2 diabetes of 10 years, plus without any, you can see that target organ damage is not there, plus one additional risk factor. For young patients of less than 35 years and diabetic type 2, which is less than 50 years, duration of less than 10 years, without risk factors come to the moderate risk classifications. This is how the ASCVD risk calculator specifically mentions. So clinician physician has to be discussing with the patient, and the risk factors have to be identified. The benefit of therapy has to be targeted. And if the risk is uncertain, the coronary artery calcium score can be used, and definitely based on the results on the lifestyle modification and drug therapy. So the fallacies have been identified because initial studies were not robust for powering for the diabetic populations. So role of aspirin in primary prevention of cardiovascular was debatable, and it is still debatable in primary prevention, whereas in secondary prevention, it is definitely well demonstrated. The fallacies for the primary prevention was including that heterogeneous patient population, the risk factors, the progression, the low dose aspirin, all these factors have to be, the weight is also one parameter has to be addressed. The post-hoc subgroup analysis of RCTs are also not properly balanced in these studies, which is also important in our population because the cost factor, utility analysis has not been captured. So now evidence-based era, the last several years, ongoing studies are published. So we can see here neutral results of effectiveness from the Creto et al. Studies, the women's health studies, JPAD studies, the JPPP studies, ASPRI and ARRIVE. So I think you are already familiar with these studies. So the inclusive studies are the PHS study, peripheral heart study. The prophylactic use of aspirin for diabetic population was the physician's health study, which is what is not unequivocal. We can see that antiplatelet trialist combination APT study was showing that at least the 4% benefit compared to the placebo was there, whereas the early treatment of diabetes retinopathy study, including aspirin for diabetic prevention of CVD, definitely showed 3% difference in the placebo, whereas 6 to 7% difference was seen in the US, the medical studies. The latest studies was published from Journal of American Cardiac College, which shows that number needed to treat is also important. So for preventing one event of the myocardial infarction, you have to treat 357 patients with that in MI, and we can see ischemic stroke is 500, transient ischemic are 370. And for cardiovascular events also is a good number is there. Whereas for safety, which is the major thing, which is what highlighted for the side effects for the uncertain benefit. So number needed to harm, for major bleeding, it is 222. So that is that bleeding is definitely a proper issue. And the harm in intracranial bleeding, definitely. So to prevent a harm, definitely there is 1,000 patients here and 1,000 patients need to harm. But gastrointestinal bleeding, only 385. That is the major, the Achilles heel in treatment of diabetes in these patients. So what about the prophylactic aspirin, the prevention studies? The newer studies are more powered and more recent studies are more well conducted. And the estimated risk factors, that generally the actual risk factors has been definitely more compact. So the clinical dilemma exists in identify which patient benefits and the possible risk benefit pharmacovigilant aspect. So which patient can progress to bleeding risk and independent of the baseline cardiovascular risk. So the bleeding risk is very real and definitely is the hindrance towards up titration or double dose of aspirin. So the older trials, definitely the post-hoc study where studied benefit risk for prophylactic aspirin, it becomes favorable for more than 10% estimation of cardiovascular, 10-year cardiovascular risk. And these risk complication increases rapidly once the individual is more than 70 years of age. So the basic challenge is definitely to identify which percent population has got an absolute risk for cardiac risk balanced with the predicted risk of bleeding. So this is why the ASCENT study is being very much propagated. And I'm sure that the chair had alluded to this study. So the age of 40 years and above without evidence of ASCVD, and the primary endpoint was serious vascular endpoints like MI, stroke, CA, DIA, and also they tracked the major bleeding events as safety outcome, the follow-up period of 7.4 years. This included 75% patients were on statins, and basically the R diabetic population included like on smokers, and hypertension of systolic BP of 136 and body weight of and TMI of 30.7. This was published in NEJM 2018. So this included more sensitive cardiac biomarkers, and compared to that, the initial studies had smokers 25%. This is concluded like lower proportion of smokers were recruited. This was an unbiased study, and large sample size was recruited, and they detected a relatively risk was also there. And definitely this showed that the incidence of fatal bleeding and hemorrhagic stroke did not differ between the subgroups also. So we can see the contemporary care effect is also important, because whenever we start aspirin, the concomitant use of statin therapy is very realistic. And both things put together contributes to the atherosclerotic endpoints control. So this is largely counterbalanced by the high risk of the major bleeding studies. So we can see that the body weight is also one of the major things which has to be considered. High dose aspirin for the body weight of 90 kilo and more has been seen, but definitely we can see that the meta-analysis has shown that the aspirin is better, but you can see that even in a patient of body weight of more than 70, low dose aspirin still there, and we can see a population that has at least harm is also seen in those subcohort. So I think you can see that overall absolute risk is only 0.6% reduction, but there is no difference in all-cause mortality or the cardiovascular benefit at the additional risk of major cardiac or the major bleeding events also. So you can see the box and whisker plot. We can see the individuals at risk of major cardiac endpoints. All these studies have shown that allocation of aspirin produced a significant 12% reduction in the non-fatal cardiovascular events compared to placebo. But what are they at the risk of increasing the major cardiac bleeding events and upper GI events by 29%. So that is the reason why we are all debating in this aspect. So I would like to summarize by the overall data. We can see these studies being contributed, the pre, the 2000 and the post 2000. We can see diabetic individuals are recruited more and more vigorously. And the ARRIVE study is the latest study included the moderate cardiovascular, which is what we want to know from this is actually the most important study. And the ASCENT study has been published with the endpoints, which has been totally important, justifying that it is only for secondary prevention, not for the primary prevention. So overall, we can see the forest plot showing that the tendency of aspirin is more towards the worse outcome when major bleeding is definitely endpoint, and only a marginal benefit of we can get achieving an all-cause benefit in the cardiovascular endpoint. So this is again, you can see that the tendency towards erring towards the bleeding is more, and producing all-cause mortal benefit is also less. So what does the guideline tell us? So guideline recommends that low-dose aspirin can be considered in those risk factors more than 50 years or more, at least one major end factor like family history of premature ASCVD, hypertension, dyslipidemia, smoking, albuminuria, or at no risk of bleeding. It's only a grade C recommendation, a very low rate of recommendation. And benefit is definitely only a bleeding of not there. And we can see the European Society of Cardiology also agrees with this, and the only for the very high risk patient been considered in the population. And it's only used for the level B in patient with moderate risk when it is not recommended for primary prevention. So my dear friends, we can see ADA 2023 has also agreed with what we have been discussing today. And even the journal, we can see Nephrology Association also been very unanimous. It's only used for any selective populations and those populations which definitely has a lesser risk of bleeding. So this is one which is definitely to be summarized. Then an antiplatelet therapy with aspirin is used in patient only at low risk of bleeding, and those at very high risk of diabetic progression in the family premature ASCVD risk. It's very uncertain regarding balancing the benefit and risk. And practically, because of so many considerations for additional benefit is not sure, definitely it is a case-to-case basis and an individualistic approach. And there has also been studies of aspirin resistance, that is the benefit is not sure in those patients, and which is why the prescription of non-compliance, non-absorption, interaction with brufen, other risk factors, cellular factors, and pharmacogenomic factors, which definitely hinders the primary prevention as such. And it is definitely compared to the clopidogrel, the Capri study has shown amount of superiority of this over monotherapy also. So it is a very debatable point. I think this holds a very important in our setup where we have to use low cost, low agents and in a proper manner. So I want to conclude by sharing you some research gaps. So we have to improve the risk stratification scores. We include the coronary arteries calcium. We have to tailor aspirin dosing and improve the systemic bioavailability of aspirin and preventing the bleeding risk. And also dose-dependent risk factors. We have also seen some studies on cancer prevention studies, but not very sure about the long-term risk. So this is what the pharmacologists have been, pharmacovigilance have been doing, decision support tools, in risk with the aspirin, cancer prevention, all these have to be included in our population. And also identify a proper biomarker. So we can see for hypertension, we can measure BP, for statin, we can measure LDL cholesterol. For aspirin, what is the biomarker which is being used? It is not sure, which is where the metabolomics, the lipidomic studies have been properly getting analyzed. And I'm sure that by the next few decades, the more studies will be published in this aspect. So my dear friend, where are we standing now? The 2018 guideline trials are supporting a major risk for stratification. Aspirin may prevent the non-fatal MI, but at the risk of the bleeding. So modern approaches have to be very individualized on the higher risk of ASCVD and the lower risk of bleeding. And which is why withdrawal aspirin therapy have to be considered wherever it is inappropriate, and longer follow-up of the studies are very important for the studies. So I would like to conclude with the IDF and the ADA consensus, which has told that we have to usually incorporate the 6 realms of the blood pressure control, the physical activity, proper use of aspirin, and control diabetes through diet, exercise, and using the major proven drugs factors, and reducing the risk of progression with cholesterol lowering and preventing the smoking. So I thank you for the kind listening, and thank for the West Bengal chapter for giving me this opportunity to learn more from this regard. And also welcoming you all to the conferences which we are conducting at Prayagraj, which is the 5th annual conference of MPPCOS and IPAD, and also the Indian Thoracic Society of Thyroid Society in Kochi in May. Thank you all for the kind listening, and sorry for any glitches. Thank you.
Thank you, Dr. Shenoy, for this wonderful deliberation. So we are really delighted to have you with us, and it is an excellent presentation. But unfortunately, as we are lacking time, so Professor Mukherjee has another meeting, so he had left. So just before your presentation, so now we may take some question if delegates want, they can unmute themselves and they can ask question directly. I had enabled them to, they can unmute themselves. So requesting all that delegates who are there, if you want to ask some questions on the before session, that is the cardiac autonomic neuropathy detection session, and the current this session taken by Dr. Shenoy. So you can unmute yourself and you can raise your question directly to us. So you can unmute and you can ask question. So one thing I just want to ask you, Dr. Shenoy, that
yes,
you had tell us about the risk-benefit analysis when we are talking about aspirin therapy in primary prevention. So what are the key take-home message from you if I am seeing one patient in my clinic and I want to prescribe aspirin or not to prescribe aspirin? What are the key factors that we should I should go through?
Yeah. So I had told you so many studies were published, and for primary prevention were actually more in the earlier decades, and now I think it is more realistic study. So I think contemporary care is very important. So whenever we decide to add aspirin, we should also consider whether that patient will require the statins also in that setting, because they both together control the, because blood pressure control, smoking cessation, or statin therapy, all are together. So aspirin won't act alone, and it doesn't have power enough to reduce the cardiovascular end results. And also I had told regarding the balancing the risk and the benefit. So I think whenever we are uncertain about this, because in older individuals and already a person with receiving any gastric ulcer or all those things, so those things we should always consider. We don't know which person can be suffering, and so we should be very careful in selecting that population. So I think we should balance our thoughts, and I think low dose doesn't harm is what we thought, but I think so many studies have been shown that even a 75 milligram, which what we are using, and even the double dose, that is 150 milligram has been used, but in the Western population, they are used even higher doses for primary prevention. So those studies definitely has shown that I think prophylactic use of aspirin is actually going to be more, I think, a fancy thing. We should be very careful in using that, and secondary prevention, definitely the cardiologist is also happy to do it. I asked the cardiologist this question, same question, by preparing this talk. So they were also very skeptical in starting them, because I think there are many newer drugs which are more effective and more able to control that in our population. That is what they had told, and I think debatable point. So we concluded to very happy to start, but when you follow up the person, when the person definitely benefits or not, we should take a call based on the risk for progression. Maybe 1 by 1 year we should see, because 5-year outcome data, 10-year outcome data has shown that it's only marginal benefit shown.
Yeah. And another important issue is that we are taking the cutoff age as 50 years, as suggested by our American Heart Association or some European societies. But whether if we consider it in Indian context, we need to actually reduce the cutoff age to 50 to 40 years, because already there are ample number of studies which suggest we are almost equivalent when we are 40 years of old with those Americans who are 50 years of old in terms of cardiovascular event risk. So what is your take on that?
Yes. So that is what. So diabetes is I think it was a milieu. So it's a heterogeneous thing. So when we have a patient who is diagnosed early enough, so I was telling not only type 1, type 2, all these diabetes, we are seeing so many other particular genetic forms also of diabetes. So whatever be the diabetes phenotype or whatever be the type, so definitely the earlier the onset of diabetes, the risk factors to progression is definitely to be addressed. As I have told, now we are in the COVID context also, I was seeing so many studies, even on COVID-19 studies also being shown. So I think we should address all the risk factors which a person can be exposed to cardiovascular risk, as I had agreed. So I think the ASCENT study had shown that a population lesser age group can also be recruited. And Indian data is not that much sure about in this, but definitely when you have multiple pathophysiologies involved, the multiple players involved, earlier the diabetes progression, even retinopathy progressing, we should definitely address them and cohort and continue with that in a proper way. So I think I agree with you. We should select the patient based on the age group, the risk stratification, also the gender, ethnicity, and the background of the disease.
Thank you very much. Thank you. So if anyone want to have some comments or questions, we can have that. I think we can almost 1 hour exceeded the time. We are really sorry, Dr. Shenoy, because
no, it's okay, because I was very happy to share, because it is a very new area for me, because we have not discussed this topic in usual endocrine symposia. So it's very grateful to you for, I think, giving us this chance to learn.
No, thank you, Dr. Shenoy. So I think there is no more question. So we can conclude here. And once again, on behalf of Indian Pharmacological Society West Bengal chapter, Association of Clinical Pharmacologists in India, and Inovocare e-Academy, I want to thank all the faculties who had given their valuable time with us and help us to know various aspects of diabetes therapeutics, the advance in diabetes therapeutics, starting from pharmaco-economics to diabetic peripheral neuropathy to now the aspirin in primary prevention. Thank you, Dr. Shenoy, and thank you all the delegates for being with us today.
Thank you, sir. Good night.
Thank you. Bye.